Our final speaker to round out this session is Mr. D. Chakrapani. Mr. D. Chakrapani retired from the Indian Administrative Service, is a veteran public administrator from the 1983 batch, who presently holds an honorary position as advisor for S2 Tech. His significant roles before retirement included Commissioner and Director of Intermediate Education and Secretary of Projects in the Irrigation Department, where he oversaw the implementation of all irrigation projects in Andhra Pradesh. Post-retirement, he was the Director General of AP HRDI and the Director of SIPS. Mr. Chakrapani possesses deep expertise in finance, procurement, irrigation, and education. He is a seasoned academic presence, serving as an honorary mentor at ASCI and a regular visiting faculty at prestigious institutions like LBS NAA and IIM Vizag. Please welcome to the stage Mr. D. Chakrapani.
For this unique opportunity of sharing my thoughts. When I left service, probably some of you were in your schools. And I often tell my audiences that when I was collector of a district, not many were born. The point I'm trying to make is, I retired from service about 14 years back, and I find that the world has become a better place to live after my retirement. Not necessarily because of my retirement, but a lot of exciting things are happening. After my retirement, I became director of a center called Center for Public Innovations, Public Systems. This was an organization set up with funding from Government of India through the 13th Finance Commission. Professor Kelkar, who was the chairman of the Finance Commission, felt that there is need for this kind of an organization to identify, document, and replicate these practices. So as part of that, we identified about 450 innovative practices all over the country, listed them out, and prepared detailed documentation for replicating about 22 of them all over the country. One of the best practices that I've noticed was the Arvind Eye Care system. I'm sure some of you would have had the opportunity of looking at the Arvind Eye Care system of Madurai. A very spirited, retired director of public health by name Dr. Venkateswamy felt that a lot of blindness in this country is unnecessary, needless. And after his retirement, he set up a center with 11 beds in Madurai for looking after the eye care. Not only that, he went abroad and brought the technology of manufacture of intraocular lenses in our own country. The cost of a pair of intraocular lens at that time in 1990-91 was about 10,000 rupees. And by bringing this technology and starting manufacture of these intraocular lenses in Madurai through that LICO, he was able to bring down the cost to about 100 rupees, and the most costly phaco lenses were about 700 rupees per pair. This, I think, is the most significant innovation brought about in eye care in this country. Today, the intraocular lenses, as also the eye care medicine, is exported to about 140, 150 countries in the world. And it is said that the practices of Arvind Eye Care are far better than the practices of National Health Service England. The point I am trying to make is that this spirited individual, after his retirement, sets up an institution, brings down the cost of eye care, brings down the cost of cataract operations, and what is most significant is introduces this Arvind Eye Care introduces the telemedicine. First time in the country, thanks again to a spirited individual by name Mr. Dinesh Tyagi, who is an IAS officer from Tripura Kada. He introduced the first telemedicine eye care through the ILFS, and this innovation is now being carried out extensively all over the country. There are about 200 vision centers run by the LV Prasad Institute, and another equal number of about 200 or so by the Arvind Eye Care, mostly in Tamil Nadu, where the eye care, the eye refractory errors are measured by a technician, and he dispenses the specs, and the specs are handed down in a matter of a couple of hours. This is one of the most significant interventions brought about by Arvind Eye Care, and today I think it has the capability of being used. This vision center, the vision center technician is just a 12th class or a 10th class passed student. He is trained for a period of about, let's say, 1 year, depending on the kind of training, 1 year to a little more than that. He sits in a village. He has the small equipment, cuts the lenses, and then dispenses them across the table in a matter of 3 to 4 hours. So this is a kind of rural innovation. The innovation started essentially from the center Madurai. Later on, of course, it was spread to LV Prasad Institute. LV Prasad is doing reasonably well. They have a hierarchy of hospitals which are linked through the tertiary care and then secondary hospitals, etc. We have had the opportunity of documenting, and it was in 2012-13 I found a lot of students from abroad coming and studying the Arvind model. Unfortunately, some of our bureaucrats have gone to Harvard to study this model without knowing anything while they were in this country. It has been documented by Harvard Business Review. The second important model that we studied and tried to replicate but did not succeed, it is one of my significant failures, was the integration of medical education with primary and secondary health care. A model which was started essentially by the Mahatma Gandhi Institute of Medical Sciences, Wardha. Some of you would have heard of that. Did any of you have the opportunity of going there? The Mahatma Gandhi Institute of Medical Sciences, Wardha, which was set up as a hospital, as a small hospital by Mahatma Gandhi sometime in the late 40s, upgraded into a rural medical college by Dr. Sushila Nair. I am sure some of you would have heard of the name of Dr. Sushila Nair. Sushila Nair was the health minister of this country. She started as a doctor at Mahatma Gandhi Institute of Medical Sciences. She started the hospital. And this hospital has integrated all the systems of medicine. This is the unique contribution, and this is the first rural medical college. And today, after the Armed Forces Medical College, Pune, and the CMC Vellore, this is rated as the best medical college and hospital in this country. And it's unfortunate that not many of us have been able to replicate the integration of medical education with primary and secondary health care. The problem that we have today, of course, it has now come down But when I was the secretary, I was in charge of the health corporation. We found that not many doctors were going to the villages, particularly to the rural areas. The integration of medical education with primary and secondary healthcare. What's this model? The model is that a student who studies at the Mahatma Gandhi Institute of Medical Sciences, Wardha, he adopts for all the 4 or 5 years of his or her medical education a certain number of families, and the health of these families is the responsibility of this young, bright medical student. And this is the same model which was adopted by the CMC Vellore through its outreach program, and then they have been able to successfully introduce the best of medical practices in Wardha. So I think a lot of credit should go to the people, Mahatma Gandhi who set up this hospital, Dr. Sushila Nair who started the first rural medical college at Wardha, and the team of doctors who continue to render invaluable service at this place. The third very innovative practice, which I found it very interesting, was the plastic roads. How many of you have heard of the name of Mr. Rajagopalan? Vasudevan Rajagopalan. He is called the plastic man of India. He advocates that plastics should be extensively used because he started mixing plastics with other material for laying of, in the first instance, curbs, and then in the second instance, roads. I, as director of SIPS, have had the opportunity of documenting the plastic roads. By then, this was in the year 2014-15, about 600 kilometers of roads, rural roads, have been made into plastic roads in Tamil Nadu, and it's the city of Bangalore which started the first plastic road project in the country. So this is something very unique and significant, and I think now this man has got Padma Shri, I think about 5-6 years back. He's called the Plastic Man of India, Mr. Rajagopalan Vasudevan, and we have had the opportunity of documenting. Unfortunately, at that time, we have not had these centers relating to data, documentation, etc. We have prepared detailed project documents, and probably some of them are still available on the website of SIPS, Center for Innovations in Public Systems. The next model that we've studied and we found it very interesting was, again, the conversion of human waste into fertilizers. A model which was started in China, the EcoSan toilets. Human waste is converted into fertilizer, and we found a very interesting personality in Musri near Trichy, Mr. Subbaraman. Mr. Subbaraman was advocating the EcoSan toilets. He came and set up these toilets in a few places in Krishna district. We documented that, and these EcoSan toilets subsequently have been taken up in districts like Krishna, Nizamabad, Srikakulam, etc. by very enthusiastic collectors. Now the EcoSan toilet, I think one of the bureaucrats has given a lot of support for the EcoSan toilets. And you know, China by the year 2015 had 1 crore EcoSan toilets. And I'm not saying because of this, but the productivity of per acre of land in China is much more than that of India. I mean, you would be surprised to know that China's agricultural productivity is much more, in spite of the country having large tracts of land and not having enough land to cultivate. The next model that we tried to document was the biodigesters. The biodigesters, interestingly, were those where the human waste is eaten up by bacteria. And the biodigesters were started by the armed forces at very high altitudes. The biodigester is an inoculum bacteria brought from the Antarctica, used by the Indian armed forces at very high altitudes, and it became very successful. And now a modified version of the biodigester is being used in the Indian railways now. Now, there are a lot of these innovative practices which are being used in this country thanks to the setting up of that institution called the Center for Innovations in Public Systems. I'm very happy that the CDPG is able to bring in data as a major platform, data onto a major platform, because it's much easier to share information. And I'm sure all of you know that during the COVID platform was able to do a lot of good work by sharing information in public domain. COVID meter. Now, the most significant development the country has seen as a result of COVID was an enormous coordination between the scientific community, the medical professionals, and the governance structures. Information was shared in no time. The transmission of information was just taking seconds, with the result that you were able to bring out a vaccine in a matter of less than 8 to 9 months, as against the 10 to 12 years that it was taking for a vaccine to be rolled out. And you could see the results of the COVID vaccination, the kind of significant changes that have been brought about. It also brought, very surprisingly, all of us have seen that in the case of COVID, the case fatality rate, which do you think was the state which had the highest, very high COVID case fatality rate? Any guess? Which state? Maharashtra had a very high incidence of COVID. Kerala had a very high documented incidence of COVID. The state with the highest case fatality rate was Punjab. Whereas the case fatality rate in the rest of the country was about 1.2, 1.3. Punjab had more than 2 case fatality rate. And 4 districts of Punjab had more than 4% case fatality rate. Thanks again to the documentation which has been carried out. I'm sure ICMR would find this data very interesting. There are a lot of governance processes that need to be rolled into now in the context of this. Maharashtra and Kerala, in spite of a very high incidence, their mortality, in fact, Kerala had a very low case fatality rate. It was 0.6, 0.7 if I remember right. So the point I'm trying to make is data centers, data sharing, and this data sharing was possible during COVID thanks to a very informal governance process. Today we do not have formal governance processes to share data as between one country and another. So the institutionalization of this data in terms of these platforms, in terms of these governance processes, I don't think any country has put in place a very formal governance process to share data in a very, very transparent manner. We are still grappling with major issues, and I'm sure centers like this will find it very, very, very meaningful, and I'm sure they'll find it exciting to ensure that there is a platform which is not necessarily governed by political processes, but which kicks on its own. This is what is of the essence. The COVID has demonstrated to us that human beings are capable of handling crisis, and then this is one area where we have been able to handle crisis. I always make this point when I interact with students. We had the Spanish flu. I'm sure you would realize that. Spanish flu about 100 years back. The population of the world at the time of the Spanish flu was about 190 crores. And how many people died out of the Spanish flu? About 6 crores. And 60 crores were affected. And we had this COVID, and we had a similar incidence of COVID. And something like 65 to 70 lakhs, I'm talking the formal figures, of people died. The entire credit for this should go to the documentation, data sharing, and the manner in which governance structures have not enforced themselves, though the data was being shared. I think all the governments knew the data was being shared between US and India, the data was being shared by manufacturers of medicines, etc. The data sharing helped countries to bring down the cost of medicine, to export vaccination. India has exported enormous quantum of vaccine, and that's the very triumphant claim made by the government, very rightly so. So the need for the data sharing without formal reference to political processes is absolutely essential. I'm sure organizations like this will be very, very effective in doing that. Thank you very much for this opportunity given.